All right, as we start off, good morning, everybody. We're waiting for the others. We'll just go through a recap of our last class. If you remember, we said as we learn about these laparoscopic instruments, we have to know the name, the parts, its uses, assembly and disassembly, its cleaning and sterilization technique, what its substitute can be if we don't have it, what its complications could be, and how to maintain it. So basically, this is what we need to know about each instrument. We did start with a trocar and cannula, the port. And finally, a few important points just to summarize. On the tips, we said that the primary port is always entered in a flat position, always entered with a valve open. The secondary ports are always under vision and with the valve closed. The primary ports always enter perpendicular to the abdominal wall. They don't enter at an angle because then it will be difficult to maneuver them. And when you maneuver them, you will make the inner port bigger, inner size, and that will cause herniation risk. You always keep it under vision at all times, the epigastric vessels, inferior epigastric vessels, as you enter the secondary port. You always exit under vision also to see how you came out and not leave any gas in the abdomen. And you always close any 10 millimeter or more sized port under direct vision and from the rectus sheath upwards. We discussed the entry site positions, primary and secondary. We also discussed the breakdown of each area of the valve. Now, also important, as you said, if you remember, there was this flap valve that we had talked about. So the flap valve, as you can see when you open it, right, that flap valve, this flap valve, when you're pushing in your scope, so when you're pushing in your scope to show the camera, don't push the scope to touch the flap valve, if you can. That way you are preventing damage to the scope. So what I mean by that, let's say this is the scope, okay? So when you're pushing it in, don't do this. Try not to do this. Not that it's a problem, but try not to do this. This damages the tip over time. So what you're supposed to do is you put it there and you push this valve open as you advance this, okay? So that two things will help you. One, you will not damage. Two, if there is some blood on the flap valve, you're not going to touch it with your scope every time you're going in and out and making it dirty, okay? So this is about the trocars. So that was another thing that we had said about the different things about the trocar and cannula or the port. We had also talked about these ports being closed by a port closure. So please understand that you don't close a big 10 millimeter port just on the skin. You make sure that you now take it from inside. So there are different small instruments. I'll show it to you the next time, the port closer. So this port closer are of different types. There's something called the suture passer, which we have here. Then there's something called the cobbler needle. Cobbler needle is actually the one that you would use. You would see some of these our shoemakers or cobblers use. You know, they would go this way, push it in, take a suture, come out like this, push it in. So that's a cobbler needle. So we have different ways of closing the large port defects. So very important that you close them under vision. Now, today, let's start off with the next bit of the class. We're going to start with the instrument called the Veress. So the Veress needle. Again, an instrument of access. So we are still discussing access. So an instrument of access means it's an instrument that is used to go into the patient. This instrument of access, called the Veress needle, is derived its name from Janos Veress. So he was a physician from Hungary. This physician was using or developed this for pleural effusion and pneumothorax. Okay, and now it is being used for pneumoperitoneum. How do you describe it? You have to describe it based on the length. So the length is divided into almost 4 sizes that are available. These are 8 centimeter, 10 centimeter, 12 centimeter, 20 centimeter. Okay. Then the diameter is around 2 millimeters, which is standard. It is called spring-loaded. So you can see when I do this, so there is a spring here that you can see when I push, it goes through. So the moment I push this on something strong, the spring goes back, and this needle, the needle comes out. This needle then pierces through the skin and the peritoneum, and as soon as it crosses the peritoneum, so you can see this, as soon as it crosses the peritoneum like this, you will hear a click, and that's because that spring comes out and it protects the bowel from the sharp needle. So this is spring-loaded. It has 2 parts. It has the shaft and the stylet. So this is the shaft and the stylet. This is the spring-loaded mechanism. So these parts you have to understand and how they connect. So few things about Veress needle. Number 1, how would you want to use this? Before you use this syringe, before you use this, we always need, I need a syringe with some saline. Just check in there. So before you use this, you actually need to know its tests or checks. So always check patency, number 1. So because when you've used it the last time, maybe something got stuck here and you'll not be able to use it properly the next time. Make sense? So you check patency. After patency, you check the spring load mechanism. So you do that. Okay? You have to check that this spring springs out. Make sense? If it does not spring out, then that means even when it goes in, it will not spring out. Okay? So it could be a bit dangerous. It's defective. You have to be careful. So patency and spring out. Third thing, how do you hold it? You hold it like a dart over the shaft. So this one you don't hold like a gun. You don't hold like a pistol. You don't hold with this mechanism. You don't hold this part. You hold the shaft. Okay? So how do you hold this instrument? So just a syringe. And then we leave this here. Okay. Just fill it with that. Fill it with the water. Just from here, this way. Direct, okay? So you hold it like a dart over the shaft. Agreed? Then, where to hold? So basically now, what do I mean? You could hold the shaft here, or I could go and hold the shaft here. Make sense? So again, just guides. These are not rules, these are guides. The guide is such that you want to make sure that this goes through the abdominal wall, perforates and clicks, but does not go all the way down to the aorta or the vena cava down there. all right? Because that's what this thing has been also found to do. If you're not careful and you just go tuk, you'll go and hit the vena cava or the aorta, okay? So you don't want to do that. So how do you get? A rough idea is, if you take a pinch of the abdominal wall, because for this you'll have to lift the abdominal wall. So if you take a pinch of the abdominal wall, and it is around 4 centimeters, add around 4 centimeters to that, so take around 8 centimeters roughly, and then hold it. So you'll have 4 centimeters of that, and your finger will reach where it's supposed to reach. It will not be so deep. Are we understanding? So if you hold shorter, you will not reach the bottom. You'll not go through. If you hold too far, you'll go too far in. Are we understanding? So roughly, that's a guide. Then another thing, what are the structures that you will go through with this on the abdominal wall? Anybody? The skin, right? Next. Subcutaneous tissue. Then? Really, guys? Abdominal wall? The rectus, sheath, some muscle, the peritoneum, and in. Agreed? Of these, there are 2 structures which are called plastic structures and others are elastic structures. Okay? Which are the main plastic structures? Which means they can actually stretch a bit. Skin can stretch. Okay? What else can stretch? The peritoneum can stretch a little bit, right? The others are elastic. You can't stretch rectus sheath. You can't stretch muscle, all right? So basically, you have these other structures that you're going through. So when you are going through, what you have to understand is, listen, you will now feel it like this, okay? So you're going through skin. Skin, you'll have to make a small nick. You don't go direct, okay? Because you'll damage this. I mean, you might, but you'll use a lot of force and then this will get blunt over time. Just make a nick and then you would go through fat easily. You'll reach the rectus sheath and there'll be a little bit of resistance. And then when you go through the resistance, you'll hear a click. Here I told you it will push. When the needle cuts through it, the spring loads out again. Got it? So you'll hear a click. Then you will go again through the peritoneum. When you reach the peritoneum, as you're going, listen, you will hear a click. Okay? So you have to remember, as you're going through this with the varus needle through the abdominal wall, there are 2 clicks you're supposed to hear for or feel for. With time, you feel, you don't hear. Okay? So you'll hear tuck, tuck. Then you know you're in. Once you're in, you do not try and now do this. You don't say, okay, yeah, no resistance. There's nothing stuck there, no bowel, all right? Because if there is bowel and you've perforated it, it's not a problem. It is like a needle puncture into a vein or into the bowel. You don't have to repair that. But the moment you start doing that, you've made that small puncture into a laceration. Then you have a problem. Are we making sense to each other? So once you have gone in through that, the peritoneum and you feel it, now you do what is called the safety tests. So you want to verify that you're in the right place. Okay? How do you verify that you're in the right place? You have to verify it by 3 or 4 techniques. Okay, 1, it's called the saline test. So what is saline test? You now you'll have a syringe ready with saline and you'll push this through. Let's say 10 cc or something. Push it through. And then you aspirate. If you aspirate it back, what does it tell you? You're not in. You're in a cavity that is collecting the fluid and then you're aspirating it back. So what should happen? You push it in, and when you aspirate, nothing comes out. Are we understanding? So that's test number 1. Test number 2, hanging drop. So you put a drop here like this, okay? So there'll be a drop here. Then you hold the abdomen and you pull up, okay? So what happens? This air gets sucked in. Remember what I told you the other day? What is the abdominal pressure normally? It's a negative, it's a vacuum. So rule number 1, anyway, I'll give you the rules. Always enter open. Remember, like in the trocar, the primary, this also goes in open. If you go in closed, this is closed across. When you go in closed and you go in, there's bowel there, you'll go in and there's still bowel there. When you go in open, you go in and air rushes in. The bowel falls away. Are we understanding each other? So you will have to go in open. But once you have gone in, you're doing your safety tests. We've done test number 1, saline test. Test number 2, hanging drop test. Test number 3, you can actually take this saline and remove this plunger. If I pull this out and then just put saline here and I leave it this way, okay? This will, by gravity, just keep on going in. I don't have to do anything. But if it's a closed space, this fluid will not go in. You've understood? So here I'm not pushing in, I'm just removing the plunger and leaving it here. And what will happen? It will push in. Are we getting? It will just go on inside. And the 4th one, the 3rd one I told you, the needle movement test. Isn't it? We should do that? We shouldn't do that, okay? So that's not to check that you're in. Don't check, oh yeah, I think I'm fine. There is bowel here, liver here, okay? So don't do that. And the last one is called quadromanometric test, the quadromanometric test. What is quadromanometric test? It is quadro for manometer, manometer. What is a manometer used for? Pressure. So 4 pressures or 4 values of so it gives you, there are 4 parameters you're checking, okay? So you're using the insufflator settings to tell you where you are, okay? So that we will be covering when we are discussing insufflator in detail. Make sense? But the insufflator, just to understand for today, your initial pressure that you put in, the actual pressure, when you want to start connecting this gas, you connect the gas here, and then you start it, should be less than 10. So once you're in a single digit pressure, intra-abdominal, when you put this in, you are in the right place. Are we understanding? So for simplicity, you want it as a single digit pressure on entry. If it's double digit, you're not in the right place, disconnect, come out, try again. Don't wait too much time, don't waste too much time until you've put in so much gas that if you're in the wrong place now, it's going to be difficult entering again. Are we understanding? So you have to be very sure. So tips for Veris entry. Tips, not even tips, rules. Mine, it is rules. You don't have a choice, guys. Rule number 1, patient flat. Rule number 2, Veris needle checked before entry. So spring loading and patency. You understood? 3rd, valve open. 4th, hold in the shaft. 5, you lift the abdomen as you push it in and always enter perpendicular. So rule number 5, perpendicular. Rule number 6, lift the abdominal wall below the entry point as you're pushing it. So what does that mean? If this is the patient, you don't hold above and push here. You hold below and push above it, okay? So that's your direction. Now, you might say that, Doc, you're saying entry vertical, but then you're lifting the patient's abdomen. Now it's like this, see? So this is what I want you to understand. Okay, so let's say this is the abdomen. The umbilicus is here, okay? So you have to hold here as you push this Veress needle. Now, what is important is if I put it this way, if I put it this way, it is entering at an angle to the abdominal wall. Agreed? All right. So I have said it has to enter vertical. That makes sense? So enter vertical. We discussed the entry points. There is infraumbilical, intraumbilical, supraumbilical, all right, Li Huang's position, etc. The same rules apply here. The easiest one is intraumbilical for the Veress because it's the thinnest part. It is least vascular. It is fused. There are different layers that are fused there. You get it? There is less chance of you going and getting stuck on the peritoneum or in the muscle. So it is easy to put in the intraumbilical position for this. But sometimes people have very deep umbilicuses. And when you have very deep umbilicus, you have to be careful because those deep umbilicuses are also dirty umbilicuses, right? And it's very easy to get an infection there. So you have to be careful that if you're putting it in, then that is supposed to be cleaned very well. Otherwise, it will be a problem. Got it? So what I was saying is you enter perpendicular. Make sense? But then, if you enter in perpendicular, the aorta and the vena cava are just here. Right? So what I was meaning was you have to lift this abdomen up. So when you lift this abdomen up, make sense? This umbilicus is here. Make sense so far? This is now your direction of the needle. Make sense? This direction of the needle is now 45 degrees or so to the position of the patient. Make sense? But it is still 90 degrees to the skin. Are we getting each other, guys? Because I lifted it. So now I'm 90 degrees to the skin, but I'm 45 degrees to the patient. Are we getting it? So I am still saying the same rule. Enter perpendicular to the skin. I did not say perpendicular to the patient. Okay? Perpendicular to the skin. But when you've lifted it, you've understood. So you have this, and then you lift it like this. This is perpendicular to the skin. But now it's not perpendicular to the patient anymore. So your direction should be in this sacral hollow or to the anal verge. So for you to understand, when I have done this and I'm putting it, I am directing it perpendicular to the skin, 45 degrees sometimes to the patient, and I'm directing it to the sacral hollow. So I'm thinking where the sacral hollow is, or if the patient is lying flat, you know where the anal verge is, so roughly towards the anal verge. Are we understanding each other, guys? Now that is because you're trying to avoid this part here, guys. This part here is very dangerous. People have hit it very many times. And the vessels that are most commonly hit are the vena cava or the left common iliac vein. All right? Because the left common iliac vein is pulled a bit, we'll see it in anatomy, is pulled a bit to the center. You've understood? So these two vessels are very difficult, are very easy to hit if you're not careful. It's not that easy to hit the aorta. I'm not saying it's not been hit, it's been hit. All right? People love target practice. They love hitting those things. But what I'm saying is aorta is a bit difficult because it is thick-walled, and this needle, when it hits like this, it slides and then goes to the one side. And when it goes to one side, there is that soft, thin-walled vessel called the vena cava, which is lying there, and that's what it hits more often. Are we understanding? Because the aorta, it can do this and slide off. Okay? So, now, do my rules make sense, guys, so far? All right? And I'm telling you, if you follow these rules, you will be in the green. You break one of these rules, and I kid you not, you are asking for disaster someday. Okay? So this is what you're looking for. Next, you're listening for 2 clicks. We said that. These clicks are from which 2 structures? The rectus sheath and the peritoneum. So when you hear the peritoneum click, the second one, don't push it all the way in. Now you let it be there, connect, do your safety test, saline, hanging drop, plunger, or quadramanometric. Initial pressure should be single digit. You see what I'm saying? Simple things, all right? And once you're that way, now insufflate. Start insufflating slow first, between 1 to 3 liters per minute. So don't insufflate very quickly, okay? One, the various needles capacity is only 2.5 liters per minute max. So anyway, it's not going to take, even if you put 20, the pressure, the flow rate, it's not going to take it at 20. It's still going to maximum take it at 2.5 liters per minute. So start slow, between 1 and 3 liters per minute for distending the abdomen, okay? The reason is 2 things. One, you're giving the chest some time to, because it will start pushing the diaphragm up. So when you try and distend it, zoop, okay? You will see changes in the anesthesia machine, which the anesthetist may be a little uncomfortable with. So give them time and let it slowly distend. Second thing, understand, when you have put in around 200 to 300 cc, the initial 200 to 300 cc, you test for liver dullness. It's the first sign to go. All right? So you start auscultating the liver, and you'll say, yeah, liver dullness gone. I'm fine. Okay? Let it continue distending. What is the capacity of the abdominal cavity? The capacity is around 3 to 5 liters max. Okay? So you distend this abdomen to around 3 to 5 liters in most patients, average build, and then it will have distended well enough. Okay? You don't need to worry about the volume that has been used to give that distension, because you may have leakages, you may have whatever. But what is important is the pressure. So your pressure settings of the insufflator should be put at, operative pressure should be the ones deciding how you will work. So in a normal adult, okay, we use pressures of between 12 and 15 millimeters of mercury to operate. Operative pressures of 12 to 15 millimeters of mercury. In an obese patient, we may have to sometimes go up to 18. Even in an adult normal thin patient, we may go up to 18 to 20 for initial entry, which means when you put in the varies, you can distend to around 20, so that then you can use the trocar to go in direct, and it will have given you a good distension, not to cause the dimpling up to the vessels. Okay? But that is now supposed to be brought down to 12 to 15 when you're operating. You don't operate at pressures above 15 in most situations. In an adolescent or a slightly elderly pediatric patient, you're working at pressures of between 10 and 12. Okay? And in very small babies, you're actually operating at pressures of 6 to 8, but whatever gives you enough distension. So these are guides of how much pressures you will be operating with. Make sense? The next thing is, when putting in a varies, yes, this is not like the trocar, you don't rotate. This one is just a direct push. You've understood? As you're pushing, so no rotation of this needle. Next, what are the issues of varies entry, all right, or using this to enter? Number one, you have preperitoneal entry, so or wrong placement. So where could this go that could be wrong? Your aim is the peritoneal cavity. Agreed? Where could this go that is wrong? 1, it could be pre-peritoneal or above the peritoneum. Agreed? 2, it could be in bowel. 3, it could be in a vessel. 4, it could be in a distended bladder. Make sense? So you need to know how or where this is, okay? Just by checking those parameters, and I will guide you through the various settings of the quadromanometry to tell you where you are. Okay? Next. Yes, what are the complications? Those are the complications. The problem with the Veress entry or the Veress needle is 1. This is a blind procedure. It is the most dangerous, all right, step of any procedure, the entry. Why? Because it's the primary entry that is blind. Whether you do it by a direct trocar entry, whether you do it by a Veress entry, whether you do it by a Hassan's or open technique, the first entry is a blind procedure. And it is the one that is known to cause the maximum complications, okay? Especially if you're not alert or aware. So please understand that, okay? So we've discussed about that. We know what are the other uses of Veress. Well, I mean, in situation, people have also used this to do the port closure. It can be used to direct in and pull out and, you know, the suture that you have placed in, okay? Next, let us move. So any questions so far on Veress needle? I think we've covered it pretty well. We've covered the port sites, I mean the sites of entry. We've covered the complications. We've covered the safety tips. We've covered the exact technique and the rules of using this. The different entry techniques, obviously we have Veress entry. We have direct trocar entry, which means you use this trocar directly to go in without any gas insufflation first. I use the direct trocar entry. I've done so for the last 25 years. It's a matter of getting used to what you're comfortable with. Doesn't mean I cannot do a Veress needle entry today. I still can. And I have occasionally, very occasionally, used the Hassan's or open technique, which most surgeons, general surgeons prefer. So that's the blunt entry, okay? So they would dissect and they would open, they would put a stay suture on the rectus sheath, they would dissect, they would actually open it under vision, and then they will just take this blunt trocar and push it in like that. But again, it's a blunt procedure. Don't feel that it has any more safety over the other techniques. If the bowel is stuck there, whether you use that technique or whether you use the open or whether you use the Veress, your risk of bowel injury is still the same, okay? Actually, so there is no preference over the other, it's more of a choice, okay? The risk of failed entry is least with the direct trocar entry, the one I use. The Veress needle has high risk of those things. Vascular injury is higher with Veress as well, okay? So these are different techniques. Now we go to another instrument. So part of equipment, again, vision. So we go into the telescope, okay? So this is a telescope. So when we are describing telescopes, we need to understand a few things. Number one, we describe it based on the diameter, that is the size. We describe it based on the optical axis. And we describe these based on number of rod lengths in here, okay? So, when you talk of size, we have different sizes, 1.5, 1.8, 2.9, 4, 10, 5, 12, etc. The commonest one are the 10 and the 5. Okay, but then the 4 millimeter is used in the resectoscope, the 2.9 is used in the hysteroscope, the 1.8 is used in the office hysteroscope, the 1.5 is used in the ureteroscope. So we have different scopes, got it? This is a rigid telescope. We also have some scopes that are flexible scopes, okay? The next thing you would go into is optical axis. So optical axis is the direction at which this camera is showing you. It's always written on the scope. It's always written on the scope, so you don't need to remember or mug up things. But the optical scope is, optical axis could be 0 degrees, could be 30 degrees, could be 45 degrees, could be 12 degrees, and there is some that go as far as 70 degrees, okay? So the common ones again, 0 and 30. 12 is used in the resectoscope. 12 is used in the resectoscope. We'll go into those details when we're covering hysteroscopy. So we have optical axis, we have size. The larger the size, the more the brightness and the better the resolution, okay? Then we have number of rod lengths. So when you see here, it's written 30 degrees, Hopkins, it is written autoclavable, it is written HD. So different things are written on it. That's to tell you about this scope. So the number of rod lengths, so there is something called rod lenses, which are prisms in here. And we have this described by Harold Hopkins, who was a British biophysicist in 1952. So he brought in the rod lens system, okay? And in 1966. So these rod lenses, they would have different scopes with different number of rod lenses, 8, 12, 14, etc. And the more the rod lenses, the less the air gaps in between here. Make sense? And when you have less air gaps, it means you have a better transmission of the image through this with a better clarity. So HD scopes are having very many rod lenses. The SD scopes standard would be less. Okay, that's just for understanding. Now, what are the parts of a telescope? The parts could be the eyepiece, that is this one here, which connects to the camera head. It has the light adapter, which connects the light here. It has the shaft, which has the lens, rod lens. And it has the objective lens, which is this lens. So we have an eyepiece lens, an objective lens, and rod lenses. So that's how this thing is made, okay? So in using this, there are a few things we need to understand. When I say 0 degree, this is how it will be. So let's say you have that end and that end, okay? So this is a 0 degree tip. This is a 30 degree tip. So it's trying to show you 30 degrees. So when the image is going through here, got it? And here, 0 degree. So when I'm using this scope, 0 degree, I am seeing what the scope is focusing in front. When I'm using the 30 degree, I am seeing something that is 30 degrees downwards or 30 degrees away from my straight line. Are we understanding? Now, the advantage of a 30 degree is, so when I'm holding it this way, this 30 degree, I'm seeing this. I'm not seeing you. If I want to see this, I'll have to do, if I want to see that, I'll have to do this. Are we understanding each other? But in 30 degrees, this is enough for me to see down there. When I turn this light cable that side, this is changing this side. Have you understood? When I turn this cable this side, this is now seeing the top. You've now understood? So wherever the light adapter is, I'm seeing the opposite side. So the advantage of a 30 degree is to look around corners. When you want to look around corners without moving the scope so much, because remember you have a fulcrum at the abdominal cavity. How much can you move this? All right. So instead of moving so much, you would rotate this way to see there, then come up and show me up there, and come down and show me down. You've understood. So you see, I'm doing that more than that movement. So that's the advantage of a 30-degree scope, that it shows you around corners. So you have a growth here, like a fibroid. I go beyond it and I turn it that side and it shows me the bladder. Otherwise, with a 0 degree, the fibroid is here. There is no way I can show that bladder. You won't go over this and then do that. So are you understanding? So the difference is, in 30 degrees is very useful for us as gynecologists who are working in the pelvis, which is a narrow space. All right? But many surgeons are used to using the 0 degrees, okay? Because they may want to just see the gallbladder straight like this and that's it. They're not seeing round corners. You've understood what I'm saying? Same with the appendix. Once I've held it. You've understood. But in the pelvis, I have the uterus and I have to go around it for the bladder and under for the uterosacrals and the ureter down there and the rectum. So, and I have to retain the uterus, for example. So that is the whole difference. Are we understanding? So 0 degrees, 30 degrees. Next, we go on. Yes, sometimes, even in a 0 degrees, by the way, okay, just for understanding, you see, it will not change the view whether you hold it this way or this way or this way or this way. The view is going to be the same. Are we understanding that? But how would you still want to usually preferably hold it? You still hold it, if you use 0, with the light cable on top, not this way, okay? Not because it's going to change the view, but there is something that will change. How many of you have phones? All of you. How many of you have phones with cameras? All of you. How many of you have phones with a camera light at the bottom of the phone? Ebu, look at your camera. I mean, seriously, you guys are actually looking at your camera? You don't know the answer to that? This is the phone. How many have the camera here and the light here? So, do you know what I'm saying? So even though it's not going to change the view, you want the light to come. You see, the light is coming from the top. So you want the light to still come from the top. It's just how our brain functions. We don't have something lighting it up from the bottom. Are we getting my point? So even in a 0 degree, the light is at the top of this, and then you have the camera like this. You've understood? So that's the best way you want it. Not because if I change this scope to the bottom, I'm seeing an upside down U. I'll still see a straight U because it's 0 degrees. In a 30 degrees, I cannot afford to do that. The moment I change anything, the view changes. You've understood? So what I'm trying to tell you is that you still want to do it that way. Secondly, when you have it down, remember this patient's abdomen is here. So when you do it down, the other thing is this cable will now be bent. It will be touching the patient's abdominal wall. Again, the cable is likely to be damaged when that light adapter is down with the cable down there. So for those two reasons, you still preferably want the cable on top as much as possible. Understood? Not because it's going to change your view much, but because you want the light to focus on that item from above, okay? Not try to light it from below. And because you don't want to damage the light cable. Are we clear on that? Right. So you see what I was saying is if this connects down, you see this? This will be bent like this because the patient is here. You see, you'll break this. So you want it up. You've understood? So it's a bit easier to manage. Okay, so you don't want to damage these cables because we'll discuss about the cables. One of the things about the cable is how to handle the cable. Then you obviously have to prevent fogging. Many times, those of you who have held the camera or assisted, you'll realize on and off sometimes it fogs or it becomes dirty. If it becomes dirty, you have no choice but to clean it because you can't operate when you can't see. These are things I've mentioned and they should stick, okay? So how do you prevent fogging? Why does it fog? All right? How many times have you been in a car when it's raining outside and it's cold and you're inside? And let's say there are 4 of you sitting, you're going for a party. When there are 4 of you and all breathing in that car, what happens to the windows? Fogs up, right? So how do you have to get rid of it? You either open the windows kidogo, air comes in and balances the temperatures, right? Or you put on the heater or the AC to circulate it. But you get what I'm trying to tell you. Now, why does it happen? Outside cold, inside warm. Okay? So when the scope goes in and you have the intra-abdominal temperatures that are warm because it's 37 degrees, but your scope is cold, it will fog immediately. So what do? Warm the scope. That's one option. Dip it in hot water that is sterile and warm it and then go back in. And it will fog less. Then there is an anti-fog solution that's available. For those people who drive Mercedeses, that's fine. Otherwise, I mean, not everyone can afford that. And the third one is avoid air leaks. So when you have valves, remember I talked about valves here, valves everywhere, right? Try avoiding leaks. When you have leakages, it's constantly leaking, so the area starts becoming cold again. It cools your scope faster, understood? When it cools the scope, again, you start fogging. You've understood? Yes. Good. So this is about the telescope. Any questions so far? What time is it? So then we have the video camera head. Those ones I'll demonstrate in theater. So I'll go to the theater ones and demonstrate here. We have the light source. We'll have the light cable. I'll demonstrate because I have to show something there. The monitor, the insufflator with the gas. So that's where we'll discuss about the settings. Now let's go to hand instruments. Okay, so I'm doing this here because those are very important parts, but they might need to be done in theater. Okay, so maybe the next visit, I will be in theater and we will demonstrate directly from here and we'll be communicating. Clear? Good. Yes?
You mentioned about the entry point for what's the entry point for the scope?
No, so when you've put in the trocar, the primary trocar is your scope entry. That's your primary port. So where you've put in your first port, before you put in secondary, what did I say? Secondary are always under vision. How are they going to be under vision? Because the scope goes in, after the gas is already insufflated the cavity, you go in, you look around, you explore, before you do anything, you first explore. You do not explore in a Trendelenburg position. Because if you have hit bowel, if you have hit something, and you do this, that bowel will fall off. You will never see it ever again, and then you'll not know what you've hit. You get my point? So, patient flat, you've put in your varus, you've put in your first trocar, You put in your gas, you've insufflated to 15, operative pressures are set. You're ready with your scope. You go in, and now you first check where you entered. Okay? Okay, so explore your entry point. There is no bowel that has hit. There is no big ballooning under the retroperitoneum because of a hit vessel. That's what you might see. Or there is not a lot of blood in that abdominal cavity if it's not an ectopic pregnancy, for example. It should not have. But if it's an ectopic pregnancy, you might have blood in the abdominal cavity. You've understood? Because she was bleeding. Then, once you've seen this part, you now go, while she's still flat, you go and see the pelvis. So I'm talking as gynecologist, but I mean, you look at your place of interest, okay? So look at the pelvis. Then you see, okay, that's fine, still flat. Then you go, appendix, bowel, okay, a few adhesions there, right? Then you go up, the right paracolic gutter. You go up, the liver, the gallbladder, push in diaphragm, okay, I'm still seeing, come out, falciform ligament. This side, okay, stomach, I'm seeing the spleen. You shouldn't see it. If it's seen it, then you know it's a splenomegaly. Go around, okay, the left paracolic gutter, splenic flexure up there, going down, 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 all right? The sigmoid colon, it's adhesions to the wall because that's a normal, back to the pelvis, okay? Now, once you have done that initial inspection, only then are you allowed to do a Trendelenburg position. Guys, these are rules. I've done them for 25 years. Please don't think you are any different. Don't take shortcuts, okay? I don't care what you see other people do. You have come to me for classes. I'm giving you guidelines. You will follow guidelines. Are we clear? So, not allowed. I've done over 5,000 procedures. Yes, I've not hit a vessel. I've not hit a bowel. There must be a reason why. So guys, these are rules. You do not break them. Are we clear? Good. Once you have done this initial inspection, you now do head low, and you enter the secondary ones under head low. Why? Because when they are flat, now all this bowel is still in the pelvic area. Okay? So you don't have space. I mean, you're doing it under vision, it's fine, but you don't have space because there's a lot of bowel. But when you do head low, this bowel moves off a little bit. Now you have space, okay, to put in your secondary ports. Are we clear so far? Yes. I hope that answers your question. Good. Yeah, I mean, that's what I said. If you have any questions or doubts, just ask, because there is no way I will remember to take you through every single step. There are things I might forget, but that I might want to tell you. You see, now I've told you about how you inspect the abdomen, actually demonstrating it all round, the way you should do it. Are we clear? So this is very important. Now we go to hand instruments. Time? We have half an hour. Good. So hand instruments, what do we use these hand instruments for? So these are all hand instruments. Hand instruments are the ones we would use now to operate. So they're very important. They are divided into reusable and disposable. The most common ones we always work with are reusable because they are economical. I mean, if you have to open a new scissors and open a new Maryland graspers and a new every time, it's not going to work, okay? So you want to use reusable instruments, not disposable instruments, but there are centers where they use disposable set every time. That becomes very expensive, but yes, I mean, it's an option, okay? What is an ideal instrument, laparoscopic instrument? It should be easy to assemble and disassemble. It should be sometimes having some interchangeable parts between similar instruments so that you don't have to have one instrument that has parts that can never mix with a second instrument. All right? Because that way then you'll have so many instruments, and secondly, when you disassemble and assemble them, You'll have to now sit down with a jumble box and think, this sheath belonged to this instrument and this handle, and this sheath belonged to this instrument. Imagine that kind of a scenario, because they are not matching each other. You're going to be in a problem. So when you buy instruments and you're buying 2 instruments from this company and one from here and one from here, you have a problem. I'm not saying don't do it, but then you have a problem, because you'll have to figure out which sheet belongs to which instrument. Are you getting it? So sometimes buying a set that is from one company makes better sense than to keep on interchanging. I mean, even me, I have 3 or 4 different types of instrument sets here, but I keep them as sets. You get it? So it's one company, one set packed separately, one company. So I know how to mix and match them among that company. You've understood? I don't mix this company with this company instruments. Then it will be difficult to use, okay? The third one, it should be easy to clean and sterilize. And obviously when I say sterilize, preferably it should be autoclavable. So the material should be high quality, that is autoclavable. It should have a simple design with minimal joints and hinges. So you don't want to have too many joints. It should be insulated well. And it should have a good rotatory capacity at the tip. So you see, it should be able to rotate at the tip nicely and easily. The mechanism should be something that's easy. You can hear me trying to rotate this instrument, because there are times you'll have to cut this way and then this way and then this way. So you have to be able to rotate it, okay? The instruments are available in different sizes. So lengthwise, they are available as a 20 centimeter for pediatric. We have a 28, a 36, and a 45 for bariatric. The commonest is 36, which is this one. So this is the standard 36 centimeter instrument, okay? The diameter, you have a 3 millimeter, you have a 5 millimeter, you have a 10 millimeter instrument. Okay, so those are common instruments. We even have some that go up to 15 millimeter, all right? So the common ones are again 5 and 10, that's for us, but pediatrics use the 3, okay? Even microsurgery, we use 3. Microsurgery is, for example, surgery that is like tubal surgery. When you're doing tubal surgery, you may use 3. Why? Because they're very fine scissors. Fine instruments you want to use on a fine tissue like the fallopian tube, okay? The next thing is parts. So each instrument is divided into, different companies have different ways of it, but you will have a handle. So I'm now disassembling it, a handle. You will have a sheath. You will have an insert, and you may have a cap. So these are 4 parts of an instrument, okay? And obviously, given few variations in different instruments from different companies, their assembly mechanisms are different, okay? But it's important that you know these sort of parts. How do you describe instruments or divide them? They are mainly divided into, hand instruments are divided into dissectors. So anything that you can use to dissect. Graspers, to grasp. And they are divided into atraumatic or non-traumatic, then traumatic, and semi-traumatic. Okay? So the graspers are atraumatic, non-traumatic, atraumatic is non-traumatic, semi-traumatic, and traumatic. Then we have needle holders or needle drivers. We have scissors of different types. And then we have others. There are so many now. You can say suction cannula, click applicators, some manipulators, energy instruments, right? Retractors, etc., etc. So we'll cover up as many as we can, but the most important ones are the ones we are going through now. So When we talk of division of these instruments, first before that, let's just quickly go into the assembly. So assembly for this instrument and many of them is first the insert into the sheath. Okay, so this one has threaded ends here, so I'm threading it. So insert in. Now when I have this insert in, I want us to see something here. All right, when you close the insert, this ball comes out. When I open the insert, the ball goes in. Close, open. Okay, so I want you to go through. Let me send you one of these your way. All right, so all I want you to see is what happens to the ball when you open the jaw and close the jaw, okay? So pass it round. So when you open the jaw, the ball goes in. When you close the jaw, the ball comes out. Now that's important. Why I'm saying this is, guys, people don't know how to assemble these things. So when you assemble it, for example, this one, you'll have to have this closed so that the ball is outside. This open, because even here, this, when it's open, this comes out, and when it's closed, it goes in. Can you see that? So you can't do this and this. It will not. How are you going to connect this? So you have to understand also that, listen, it's not about forcing these things. Don't force them, you'll break them. Okay? Close this so that the ball comes out. Open this so that this joint comes in, the socket. And then it's very simple. This just goes in, and then close it. It's already holding it. Now you just take the cap and cap over this. Are we getting it? So you see, it's very simple, guys, but it's not that simple. People still destroy these things every day. All right? So you have to know how to take care of these instruments. Now it's ready. Okay? So that is important. You will also see this, so you can see what happens, and then you understand what I'm saying. Pardon? No, just force this open. What I'm saying, see what happens to the ball. All right, so you see this, you see open, see what happens to the ball. So you're trying to see, so you want the ball out and this out to be able to match them. If you don't, how will you match them? All right, and that's how people destroy these instruments. All right? Take care of them and know them. The problem is we as surgeons don't know most of these things. Forget this. When I take you to the equipment is when you'll realize how many of our surgeons actually understand that. If we think it's enough for us to know how to do a hysterectomy and go in and cut and buzz and cut and buzz, and if the rest belongs to the nurse to do, that's wrong. It's wrong attitude, all right? Because you should know, you as the captain of the ship should know everything about every instrument there, all right? I am the one people should fall back on when there is a problem. When I tell them, yes, connect gas, they should be able to connect. But if I don't know how to connect it, how will I guide them? Are you getting what I'm trying to tell you? So I should be the one they fall back upon. Not me falling back on them and saying, Sasa, pigi to a company. I mean, seriously? You get what I'm saying? But these things happen. I mean, you may laugh over it, but these things happen. Because ours is to operate, not to connect the energy and to do the settings down there. And what is 30 and 25? And now how do I change the foot switch is not working? And I mean, seriously. That's wrong. We should know it all. You get it? So that's what I'm going to train you people in. You understand? I told you, I'm not here to train you on how to do a hysterectomy. I mean, unless that was a fellowship program, then I'll take you through it myself. But otherwise, my job here is to convert you open surgeons into laparoscopic surgeons. For that, you need to know these things. All right, the depth, the this, the that, how do you move it, the ergonomics, the positioning, the placement, that I'll teach you. All right. So when I talk of these instruments now, we'll go into division of different parts. How do you describe them? So we have, I told you the graspers. So let's start with graspers, okay? Graspers, we said, were atraumatic or non-traumatic, traumatic, and semi-traumatic. Let's start with atraumatic. So atraumatic is normally double, you see this? Double action. Can you see this? This is called double action. What does it mean? My instrument is going this way. That's called double action. This is single action. You've understood? One moving, the other one not moving. So double action and single action. A non-traumatic is normally double action. Preet, come. Okay? So, if I am to hold Preet with two hands like this, okay? Preet, pull it out. Pull it out. Now, do you see? It's a weak grip. Come here. This is a steady wall, okay? Yes. Now, I have single action. Cool. Now I've held it. Pull it out. Are you understanding what I'm saying? One solid, one moving. When one solid hand holds another one, this is steady, it's a very strong grip. Are we getting the difference? So most double action instruments are weak graspers. I'm just giving you an example. Have you understood now? So weak grasper, so when you're trying to hold bladder, bowel, liver, you need a weak grasper. You don't need something to go and squeeze it and then destroy it. You've understood? So, rule number one, most double action instruments are weak. Number two, they have low serrations. So when you look here, these serrations are fine. They are fine serrations. These are called serrations, okay? So they are fine serrations. Thirdly, they are fenestrated. You see this? This is fenestration. So I'll pass it round. That is a fenestration on this instrument, which means the instrument has. So number one, it is double action. Got it? It opens this way. Number two, it has fine serrations. So very fine serrations here and here. Fine. Number three, it has fenestration. So if you look at it, this is the top, it will have that. That's a fenestration on the jaw. Okay? So it's not a solid jaw, it's a fenestrated jaw. Okay? And finally, this is therefore, this instrument can cause what is called irreversible elastic damage. Irreversible elastic damage, which means that when it holds it and you release it for a while, you may see some mark there, but if you look at the same area in 5 minutes, that mark is gone because it was just elastic damage. It's not a plastic damage. It's not a damage that you will see even a day later. You've understood? So that is an elastic damage. So you can hold tissue that you don't want to damage with this. And normally in our field, therefore, that would be bowel, bladder, and things like that. Are we understanding? You can even hold the ureter and pull it aside. There's no problem because it's not going to damage it. You've understood? So that is called a non-traumatic or atraumatic grasper. So go through it and then we'll see. So then at the end of this class, if I give you an instrument and say describe, my friend, you'll have to describe it every single part. This is 5 millimeter, non-traumatic, You'll have to be singing songs for me, all right? But that's what I meant. So a non-traumatic grasper is not necessarily called a bowel grasper. That's what people call it, all right? Give me a bowel grasper. But when I use that same bowel grasper to hold the bladder, am I now calling it a bladder grasper? So you see, it's divided as non-traumatic, traumatic, and semi-traumatic. Okay, give me a semi-traumatic, give me a non-traumatic. That's how it should be, not give me a bowel grasper. Even I say it bowel grasper because that's what our people understand. You've understood. But ideally speaking, non-traumatic. Are we clear? Second one, we go into traumatic. So yes, so we have a traumatic one as well. So what is traumatic? Number one, most traumatic, this is not traumatic, most traumatic now will be single action. Okay? So what is single action? Remember what I told you? It will have one that will be straight and one that will be doing that. You've understood? So that is single action. Two, it will be toothed. So here it will be having teeth that go and lock into each other. So you can have what is called 1 by 2, 2 by 3, 3 by 4 teeth. That's how they divide them. So when I say 3 by 4, it means 3 teeth here and 4 here that go and lock into each other. You understand? Or 2 here, 3 here that go and lock into each other. So it's 2 by 3, 3 by 4, 1 by 2, etc. Or tenaculum, where it's 1 by 1. All right? So for example, this one is 3 by 4. Okay? So you can see this is a 3 by 4. This one is you press this back and then it will open. When you lock it, it goes. Press this back, it will open. Okay? So it's different mechanism for different instruments. So basically, toothed, mostly single action. They could be double action, like a tenaculum will be double action, but mostly single action. Then if they have serrations, they will be very thick serrations. Okay? And they'll not be fenestrated. There'll not be fenestration on that instrument. It will be a solid instrument. And this tissue, this grasper that is traumatic will puncture the tissue. It will puncture the tissue. It will not even make an elastic, a plastic injury. It will actually perforate. Has this come your way? Pass it behind. So it will puncture. So you only use it to hold a tissue that you might want to remove. Okay? So if you want to hold a fibroid because you're doing a myomectomy, that's fine. All right? But you don't hold it on tissue, use it to hold tissue that you want to retain. Otherwise, you've punctured it and it will start bleeding. You will have damaged, okay? Then you have the semi-traumatic, which is in between the two. So they do have serrations. They are a bit deep. They do have, they could have single or double action. They could be fenestrated or non-fenestrated. And they can cause a plastic deformity, which means they cause a little bit of a long-term deformity. So you can use it for the uterus and things like that, or even the ovary, but you're not removing it, but you can at least get a good grip. So for that one, you can use it for holding tissue that you may want to retain or remove, but that you don't mind having the plastic deformity. This is single action. See, single action 2 by 3. Single action 2 by 3. That's how you describe that. I want a traumatic 2 by 3. I want a semi-traumatic. I want, you get what I'm saying? A traumatic 10 millimeter. This is a traumatic 10 millimeter. The other one is semi-traumatic 5 millimeter. So this is how you describe them. Got it? Any questions in description of graspers? Any questions in description of graspers? Yes?
Why use semi-traumatic if it's
Because when you see, non-traumatic will never grip. So let's say you want to use something to lift the uterus up. When you use those non-traumatic graspers, you're never going to be holding the uterus up. It will always fall. So you know the uterus is forgiving, but you want to do something in the pouch of Douglas, you will have to hold this uterus to lift up, or lift this way to go to the bladder. How will you do that with a non-traumatic grasper? So you don't want to use something very traumatic, but you also don't want it to not hold. That's where comes the semi-traumatic. Or the ovary, you want to lift up to see behind there. The non-traumatic one will just slip. Every time you're doing this, it will slip. Okay? So yes, with experience, I could hold the ovary and flip it with a non-traumatic. Okay? But in most people's hands, those organs are very slippery, apparently. Don't laugh. People are laughing. They're very slippery. And then they say, but doc, I held it, it slipped. I held it, it's slipping. Me, I'm wondering, but it never slips with me. All right? So I thought maybe it's very slippery with some people. All right? But that comes with experience. So you see, now with me, I hold it with a non-traumatic and lift it, I'll still lift it. You've understood. But it's not going to be that easy initially, guys. Clear? Then we go to dissectors. So dissectors, we have different tips. We have curved tip, Marylands, we have the right angled, we have, so different types. So one thing about dissectors, this is used for stripping and dissecting. Okay, it's not for grasping. So don't use a dissector for grasping any instrument. It is the one you use, see, when you want to open, dissect, lift, open, push, open, like an artery forceps that you're using to dissect your way through, okay? It's called a dissector. It can be used for stripping, it can be used for window formation, it can be used for dissection. So that's how it is used. It is used for hemostasis, so it is used to hold the suture when you're tying a knot. So hemostasis is a bleeder, you go and grasp with that, you get it. So that's what it is used for. Are we clear? So that is called a dissector. So I'll show you a dissector. So this is a dissector. Now one more thing, guys. All these have handles. And some of these handles have ratchets, some of these handles have no ratchets. Okay? So what do I mean by that? See, this handle has no ratchet, which means I can't lock this instrument. You've understood? Show me the other one. This has a ratchet. Okay, can you see this? Which means now if it's open, but when I do this, see, I can't open it unless I open this first. So this is with a ratchet. So rules, any grasper should always be with a ratchet. Grasper with a ratchet. Grasper does what? Grasps. Hold. When you hold, you want to lock and hold. Otherwise, you will have to press all the time to hold. And when you press all the time to hold, after 5 minutes, your fingers will be very tired. All right? So you only grasp with a ratchet. So you ratchet it, lock it, and grasp it. Then you can be free to move it just the way you want, just like this, okay? But you've locked it. Are we understanding? Dissectors should never have a ratchet. You can't dissect with a ratchet, okay? Every time you're trying to do this, it locks and opens and locks and how? So a dissector, that one, has no ratchet. A scissors cannot have a ratchet. How do you cut with a ratchet when you're cutting scissors? Yeah. Making sense? So those ones cannot have ratchets. So again, your team should be trained on which instrument should be with a ratchet, which instrument should be without a ratchet. So this is a scissors, for example, okay? So you are now understanding the basics of instruments. That these are how they are called, this is how they are described, this is how they are used, this is how they are assembled, and this is how one should have a ratchet, one should not have a ratchet. That should be common sense after some time. So you will see people give you sometimes a dissector with a ratchet. I'm telling you, I mean, I get very pissed off in that. Because I mean, like, you should have that much common sense to know that this is a dissector that I'm going to use to open instrument like this. You can't give me with a ratchet. Are we clear? Great. How to hold the instrument. So when you're talking of holding an instrument, you're talking of two ways. You have an in-grip. This is in-grip, and you have an over-grip. In-grip, my two fingers are inside. Okay? Over-grip. This is inside, but this is on the thumb, on the palm, or palm grip. All right? Over grip or palm grip, in grip. Palm grip, in grip. Are we understanding? In grip will actually be very tiring after some time. So you have to understand that when you are using it, let's say for grasping and lifting something or traction, don't do in grip. You do this, lock the ratchet, then bring out, and now hold like this. You'll not get tired. Are we understanding? You can't hold for 15 minutes with your thumb here. You'll have a lot of pain here, guys. All right? So when you have done that, you lock it, bring out, and then relax. Now you're just a relaxed position. Are we understanding that? And an overgrip is the one that is used mainly by the assistants for holding for long periods and all. Normally, the in-grip is when you're constantly dissecting, opening, dissecting. You get what I'm saying? And with expert use, we will use both. So I'll use that, then I'll go over grip, I'll go in grip. So if you see my fingers, they'll be moving between in and out over grip. You've understood? So it's very important that we take care of our own hands. It's very difficult. It's very easy to damage this in laparoscopy when you don't use it properly. Okay? So that is how to hold the instruments. Okay? 8 a.m. Okay. So I think we can stop here. We will continue with instruments. We have the scissors, the needle holders. So I'll take you through some of these regular instruments, not all of them. It's impossible to go through all of them. And then we'll discuss from there. And then we will move to the other equipment in theater. And once we have all that, then we move on to the other topics now. Clear? Like energy, ergonomics, anatomy, and things like that. Clear? Any questions so far, guys? Nope. All right, good. Yes? Because these sheets could be interchanged. So what if you put in an instrument? You see, even though we don't use energy, it's not a bipolar, but can you see all these handles have this thing here? This white thing. What is it for? It's not a lightning pole, all right? It's not a building lightning at pole, but this is for monopolar. So you can actually use any of these instruments that have this thing here for monopolar, okay? And monopolar is the one that we normally use in all open surgeries as well. The one that that pencil that you're talking about, the monopolar pencil with the blue and yellow button that you have, that's actually a monopolar pencil. And if you connect monopolar cable here, then this is becoming a monopolar instrument. Okay, so then I can go and buzz the way we do with that. So now, if all of these sheets and these instruments are interchangeable, you imagine the one day I forget that this instrument is uninsulated and I touch monopolar on it. So it's safer to have all the sheets insulated for that purpose. Okay? I mean, I don't use monopolar on instruments. The one we use, the monopolar hook, I use monopolar on the hook, but I could use it on a scissors. I could use it on any of these instruments. So I don't use it. That's why probably you're asking me the question, because You haven't seen me do it. But these handles all have the ability to do monopolar. Are we clear? Good. Any other questions? But that's a good question because you have to think also that, frankly, why are they all insulated when we have never used energy on this instrument, right? Any other questions? You see, when you ask questions, guys, is when I think some of these things will be clarified, because you have to understand it's impossible for me to give you all the information that you need. There are some that will still remain as queries in your head. If you don't bring them out, it goes outside the window. We don't discuss it, and therefore you forget it. Okay. Although, as I've said, we are not yet done with the instruments, because once I'm done with describing them and explaining to you about them, I'll now go into the things to be done on the instrument. All right. How do we check it? What do we check? How do we clean it? How do we, some basics things. Okay. All right. Thank you. Have a good day.